Thank you so much, Dr. Pandit. It's something for us to all think about. And our next speaker, I'm going to re-invite Dr. Evan Karash back to the podium, and now he's going to talk to us about the appropriate use of gabapentinoids in the perioperative arena. Thank you so much.
The question to pose is, when it comes to perioperative gabapentinoids, what should we do? And my disclosure is the same as it was before. What I'd like to do over the course of the next few minutes is to talk just a bit about mechanism of action, side effects, and the currently approved indications for gabapentinoids, understand their role in the perioperative period and where they're effective and where they're not effective, and really to go over the risk-benefit relationship when it comes to the use of perioperative gabapentinoids. There are a lot of questions to think about in patients who are coming to the operating room who are on chronic gabapentinoids. What are the effects on immediate postoperative pain and opioid use, whether their patients are coming in on them and whether we should use them postoperatively? What's the effect on intermediate pain and opioid use, and then influences on chronic postoperative pain and opioid use? How has our understanding of perioperative gabapentinoids changed over the course of the past decade or two? What do we know currently about relative effects and side effects, risk-benefit ratios, and how do we manage these in the perioperative period? And I think if there's any underlying theme to what I'm going to talk about, is that the story has really changed over the course of time. And this whole concept of how our appreciation of risk-benefit ratios has evolved over the course of more than the past decade. Now, just to touch on the biology or the pharmacology of gabapentinoids, it's important to understand that these have nothing to do with GABA. It's sort of a misnomer. These are drugs that bind to the alpha-2 delta subunit of voltage-gated calcium channels, for those of you that are biochemical aficionados. There is no binding to GABA receptors, no binding to benzodiazepine receptors. The gabapentinoids modulate channel function. They decrease the release of excitatory neurotransmitters. They inhibit ascending and descending nerve traffic along the spinal cord. Because they're modulating that nerve traffic, they're thought to decrease the transmission of nociceptive or pain signals. The two drugs work very similarly. They have comparable half-lives of elimination. The major difference is that pregabalin is about 2 to 4 times more potent than gabapentin, and it has better oral bioavailability. Otherwise, the two drugs are relatively similar. Now, FDA indications are relatively specific. They have nothing to do with the perioperative period. I've shown the FDA-approved indications for pregabalin and gabapentin. They are similar, partially but not completely overlapping. It's neuropathic pain from diabetic polyneuropathy or spinal cord injury, post-hepatic neuralgia, seizures in children and adults. Pregabalin is approved for fibromyalgia. Neither one is specifically approved for perioperative use. Nonetheless, there is a tremendous amount of off-label use of gabapentinoids. In the past decade, they became the darling drug of vast populations of practitioners. Acute pain, opioid-sparing effects, chronic back pain, headaches, anxiety, depression, ADHD, bipolar disorder, alcohol use disorder, pruritus, sleep disorders, restless leg syndrome, movement disorders, what have you. And gabapentinoids became very interesting to the perioperative community. The graph in the lower left-hand corner shows PubMed citations of articles on ERAS and gabapentinoids in blue, or gabapentinoids in surgery in red. And you'll notice that there's just been an exponential increase in the number of studies that were published in these topics. And if you look on the very far right-hand side, you'll see that the number of those studies has started to drop off. And I think that's because there's been some recognition that the risk-benefit ratio is not what people thought the risk-benefit ratio was. So the story starts more than 2 decades ago with some very early studies that looked at gabapentinoids postoperatively and their influence on pain. This was a very early meta-analysis, and the slide on the left, the panel on the left, shows the influence on very early postoperative pain, 0 to 6 hours postoperatively, and there was some suggestion that early postoperative pain was less in patients who got gabapentin. The panel on the right shows 0 to 24-hour pain, and it shows the reduction in 0 to 24-hour pain scores, and several studies showed that acute postoperative pain was different. And the conclusion of the study was that results in postoperative pain treatment so far were promising. And that generated a lot of interest in the perioperative community. We fast forward about 5 years to another systematic review and meta-analysis that looked at prophylactic gabapentin for postoperative pain. 5,200 patients, 130 trials, and the data was for the first 24 hours postoperatively, and on average, there was a 1-point difference in a VAS pain score and a total of 8 milligrams of morphine less used over that first 24-hour period. Statistically significant, but probably not clinically meaningful. The clinically meaningful results, interestingly, was less nausea, vomiting, and pruritus, yet at the cost of increased sedation. So this meta-analysis concluded that there were small, probably not clinically significant differences or reductions in the use of postoperative opioids. There was less postoperative nausea and vomiting, but it came at the cost of increased sedation. We fast forward another couple of years, looking at the benefits and risks of pregabalin in the perioperative period, 7,200 patients, 100 randomized trials. And there were beneficial outcomes and there were harmful outcomes. The beneficial outcome was that in the first 24 hours postoperatively, patients used an average of 6 milligrams of morphine less morphine. Statistically significant, but probably not clinically meaningful. However, there was a substantial increase in the frequency of serious adverse events. Now here, pay attention to the definition of a serious adverse event. A serious adverse event is one which is life-threatening or results in death, disability, or significant loss of function, or causes hospitalization or prolonged hospitalization. The incidence of serious adverse events was 3-fold higher in the patients who received a prophylactic gabapentinoid. Minimal benefit, substantial increase in risk. So the conclusion was that gabapentinoids may have a minimal opioid-sparing effect, but the risk of serious adverse events was increased, and the routine use of pregabalin for postoperative pain treatment was not recommended. So that was the first 24-hour period. What happens if we extend this out a little bit longer and look for a week or several days postoperatively? Again, this was an analysis. Short-term pain scores on the left for 1 week postoperatively, and pain scores were a little bit lower in the patients who received pregabalin compared to those who did not. Opioid consumption shown on the right for the first 24 hours postoperatively, again, a couple of milligrams less opioid use, statistically significant, but probably not clinically meaningful. And then if you look at the longer-term outcomes at 6 weeks and 3 months, in that table in the middle of the slide, what you see is that there was no difference in pain scores at 6 weeks or 3 months in the patients who got prophylactic pregabalin. So short-term benefit, but not intermediate to long-term benefit. So opioid use looked a little bit less in the first 3 days, perhaps week postoperatively, but pain and function were not different at 6 weeks or 3 months. Now, all of these studies were placebo-controlled. If you've ever received a gabapentinoid, you will understand that the drug has a substantial sedating effect. So while these placebo-controlled trials were blinded, the patients were not blinded, nor were the observers, because everybody could tell who was sedated and who was not sedated. The first study that evaluated this rigorously used an active placebo. So it was a gabapentinoid compared to the active placebo of lorazepam. So everybody got sedated, which is a much better study design. The graph on the left shows pain resolution and the median days to the resolution of pain in the control group or the gabapentin group, and there was absolutely no difference with an active placebo. The panel on the right shows the time to patients cease using their opioids, and there was absolutely no difference between patients who received gabapentin and patients who received the active placebo lorazepam. So gabapentin did not affect pain cessation, gabapentin did not affect opioid use, and this was not different in any subgroup of surgical patients. The same investigation looked longer term, 6 months and 12 months, and asked how many patients had ongoing pain, how many patients used opioids for 6 or 12 months. And neither one of those outcomes at either one of the time points was influenced by the use of gabapentin compared to the active placebo lorazepam in that perioperative period. So the conclusion was that perioperative gabapentin prophylactically did not significantly affect either persistent postoperative pain or chronic opioid use after surgery. Fast forward a little bit to a more recent meta-analysis. 280 randomized trials, 25,000 adult patients, looking at gabapentinoids versus placebo or any other analgesic regimen. And the primary outcome was pain for up to 3 days postoperatively. And there was evidence of benefit, there was evidence of no benefit, and there was evidence of risk or harm. The evidence of benefit was that there was a statistically significant, but said to be clinically insignificant or not meaningful, 3 to 10% less post-op pain at all of the time points. There was a statistically significant, but clinically unimportant lessening of postoperative opioid use, an average of 8 milligrams of morphine over the first 24 hours, with gabapentin and pregabalin. There was, however, 23% less postoperative nausea and vomiting. There was evidence of no benefit. There was no difference in the proportion of patients who achieved what they termed appreciable analgesia. There was no difference in the frequency of postoperative pain for 4 to 12 weeks after surgery, and there was no difference in the incidence of chronic post-surgical pain between gabapentinoids or other modalities. But there was evidence of risk. In the patients who received gabapentinoids, there was an increased incidence of adverse events, including dizziness and visual disturbances. You can imagine that if we're trying to get patients up and out of bed postoperatively to physical therapy and rehab and home, dizziness and visual disturbances are not a positive benefit. They risk falls in these patients. Another meta-analysis concluded that there was no clinically significant analgesic effect opioid sparing, or prevention of chronic postoperative pain, but the risk of adverse events. The data don't support the routine use of gabapentinoids for the management of postoperative pain in adults, and they concluded that based upon their analysis, there was no point in doing more studies, because more studies were not going to change those fundamental conclusions of lack of benefit but increased risk. So where does the increased risk come from? Well, it comes from the basic biochemistry of the gabapentinoids. They have common side effects: dizziness, gait disturbances, sedation, cognitive impairment, and, as I said, visual field disturbances. And that sedation, respiratory depression, dizziness, cognitive impairment can impair recovery and prolong discharge. And we come back to this issue that no patient should be harmed by opioid-induced respiratory depression. And let me show you where this consideration comes from. This is a study that looked at the interaction between opioids and pregabalin. Specific opioid was remifentanil. People like doing studies with remifentanil because it's got fast onset and you can change concentrations very quickly. So this is a study looking at the influence of pregabalin alone, remifentanil alone, or the combination compared to placebo. And this was analgesia, cold pressor test. Get a bunch of hungry graduate students, give them drugs, tell them to stick their hand in a bucket of ice water and leave it there until they say ouch and pull it out. So what you see, remifentanil, not surprisingly, provided dose-dependent analgesia. Pregabalin provided a little bit of analgesia, and the combination together was additive. The effect of one plus the effect of the other was the same as the sum of the individual effects. Sort of classic additive pharmacology, and clearly remifentanil gives you more analgesia than a little bit of pregabalin. But they also looked at the effects on ventilation. So here what you see is that placebo had no effect on end-expired CO2, pregabalin had no effect on end-expired CO2, remifentanil, not surprisingly, increased end-expired CO2, but the combination of pregabalin and remifentanil caused more respiratory depression than remifentanil alone. So what you now have is what we call potentiation of respiratory depression. Potentiation is when one drug has no effect by itself, but it amplifies or increases the effect of a second drug. This is not a desired outcome, to see potentiation of unwanted side effects. So what you had is additive analgesia, but potentiation of respiratory depression. And the combination affected cognitive function in these subjects as well. And the authors concluded that the results questioned the clinical benefit of combining pregabalin and an opioid compared to simply using a higher dose of an opioid. Now, Jim Eisenach and I wrote an editorial about this study because the findings were so remarkable. This was in an era where we thought that gabapentinoids had nothing but benefit but no risk. But here we learned that there was risk, and perhaps the risk was greater than the benefit. We said that an ideal multimodal drug combination is going to give you greater analgesia and lesser side effects. The combination of pregabalin and remifentanil caused the opposite effect, more side effects compared to the increase in benefit. And again, it reinforced the author's message that routine use of perioperative gabapentinoids was not supported by data and perhaps was not warranted. So let's move on to focus on the acute postoperative period. What's the influence of gabapentinoids? And I'm going to share with you quickly a number of outcome studies, many of which come from the Mayo Clinic, which has a very robust database. This was a population undergoing joint replacement surgery, 12,000 patients. 24% were said to have postoperative respiratory depression, and when they looked back at the association of that respiratory depression, they found that there was a significant association with the use of gabapentin, whether the patients had undergone general anesthesia or regional anesthesia. Another study, again, a retrospective review, looked at 8,500 patients who had undergone laparoscopic procedures, and they found that the preoperative use of gabapentin was associated with postoperative respiratory depression, a 1.5-fold increase in respiratory depression. And those patients that had that respiratory depression had a longer stay in the PACU, and an admission to a higher acuity in the postoperative ward. So longer PACU stay, and they got sent to a higher acuity ward than the patients who didn't have gabapentin-induced respiratory depression, and the authors concluded that gabapentin was associated with increased rates of respiratory depression in patients having laparoscopic surgery. Another study, different institution, looked at delayed discharge from the PACU in patients who received gabapentin. Small study, 100 patients got 300 of gabapentin, a smaller group got 600, and a control group got no gabapentin. The gabapentin patients had lower postoperative pain scores, but they also had a decreased level of consciousness, and it was dose dependent. So again, this goes to the issue of sedation, if not postoperative confusion. And the authors concluded that yes, gabapentin did reduce pain scores, but it was at the cost of sedation and delayed PACU discharge. Another study looked at the risk of postoperative respiratory depression, now major respiratory depression, as measured by the use of naloxone. A retrospective review over the course of 4 years. And what they found was that in this review, 120 patients received naloxone in the PACU, and they found that the patients who are on chronic gabapentinoids, which were increased, or continued rather, before and after surgery, had a 6-fold greater incidence of receiving naloxone compared to those who had not received gabapentinoids. So their conclusion was that the continuation of chronic gabapentinoids into the postoperative period was associated with increased naloxone use to reverse sedation or respiratory depression. So now we're seeing risk of postoperative gabapentinoids in addition to the routine use of preoperative gabapentinoids. Relatively recently, a postoperative review, 176,000 patients undergoing colorectal surgery. This is out of the Premier database. 4,700 patients had received gabapentinoids on the day of surgery. What they found was that those patients who received gabapentin or gabapentinoid on the day of surgery had less postoperative opioid use on the day of surgery, 2.5 milligrams less, statistically significant, barely, clinically meaningful, not. There was a greater use of non-invasive ventilation postoperatively, and there was greater use of postoperative naloxone to treat severe postoperative respiratory depression. So the conclusion of these authors was that gabapentinoids on the day of surgery were associated with only slightly less opioid use, but higher odds of the need for non-invasive ventilation and naloxone to reverse adverse effects. What about large-scale populations? This is a study of 5.5 million surgical admissions. The incidence of postoperative opioid adverse effects or overdose was much higher in patients who received opioids plus gabapentinoids compared to those who received opioids alone. The hazard ratio for opioid overdose was nearly 2, respiratory complications 1.7, and unspecified opioid adverse effects was 1.8. But there was no difference in postoperative opioid use. The only factor was the concomitant use of gabapentinoid along with an opioid. So the conclusion was that perioperative gabapentinoids were associated with an increased risk of serious opioid-related adverse events, such as overdose or respiratory complications. Another look at perioperative gabapentinoid use, and this is generalized adverse events. Nearly 1 million surgical patients, all older than 65 years, and gabapentin use on the day of surgery and or postoperative day 1 or 2 was associated with a greater risk of delirium, a greater risk of new antipsychotic use to treat the complication of delirium, and a greater incidence of pneumonia postoperatively, presumably because these patients may have been sedated. There was a dose-response relationship between the gabapentin dose and the increased risk of delirium or pneumonia. Delirium risk was greater in patients with renal function because dose was not adjusted, and the conclusion was that we should reconsider the use of routine gabapentin use in the perioperative period. And an editorial which accompanied this article in JAMA says, we need to unwind the automaticity of gabapentin use in the perioperative period. In other words, stop giving it to everybody as a matter of routine. When we look at subpopulations or specific populations, these were a couple of look-back reviews at the use of gabapentinoids in children, one of which said there's not a lot of evidence for the analgesic effect or the safety of gabapentinoids in children, or to support the clinical use of gabapentinoids either prophylactically or for treatment in children and adolescents. The other systematic review said that the current data on perioperative gabapentin use in pediatric patients is not sufficient to support the routine use in pediatric perioperative circumstance. What about after cesarean delivery? Recently published study came out of Stanford looking at the use of gabapentin versus placebo after cesarean delivery. The graph on the left shows opioid use, and you see there's no difference whether the patient's got gabapentinoids or not. The graph on the right shows pain scores, and there's no difference whether patients got gabapentinoids or not. No significant difference in either. And the author's conclusion was that gabapentin should not be routinely prescribed for outpatient use after cesarean delivery. So if we look at this in total, there was a tremendous amount of what we will call infectious enthusiasm over the use of perioperative gabapentinoids. But what we learned is that over the course of about 2 decades, the evidence of benefit steadily declined and the evidence of risk steadily increased. We know that the use of gabapentinoids in the perioperative period became relatively routine. And people did it because they thought that they were beneficial, that they would decrease opioid use, and they would decrease postoperative pain. But those indications were really not supported. Now, this may have changed most substantially with the FDA warning in 2019. This was a black box warning that was put on gabapentinoids about the risk of interactions with opioids and the risk of respiratory depression. And although we had been talking about the risk in the perioperative period, it may be that this black box warning was the nail in the coffin, if you will, about the routine use of gabapentinoids in the perioperative period, and that the FDA required the manufacturers of gabapentinoids to put new warnings about respiratory depression in the label for the drugs. So what we saw was that when we started the story, we thought that there was all benefit and no risk. Over the course of time, this calculus changed, and I think where we are now is that there's probably more evidence of risk than there is evidence of benefit. So the question was, did we go all in too soon? Did we not have the sufficient database to be routinely prescribing gabapentinoids to all patients? And I think we now understand that that routine prophylactic use is not supported. So what do we know? Well, we know that there's a small benefit in terms of reducing opioid dose, but that benefit is statistically significant but not clinically meaningful. No difference in the outcomes of acute or chronic pain. No difference in functional recovery. There is a risk of postoperative sedation, dizziness, delirium, respiratory depression, and opioid-related adverse effects, and their routine use is really not justified. But the question is, why are they still being used so ubiquitously in the perioperative period? Well, I think there's probably several reasons. One is good intention. And when I talk to my colleagues, particularly the people who treat chronic pain and use gabapentinoids relatively frequently, they say, well, we don't have anything else to use. There was all the concern that was generated by the opioid crisis, which I told you had nothing to do with the perioperative period, but people suddenly decided that, well, maybe we shouldn't use opioids, and the only other thing they had was gabapentinoids, thinking that they would be useful. The early research was frankly misleading because it really overemphasized that very, very early postoperative period and those very small differences in opioids. And some of those short-term outcome measures could be a little misleading because they were indirect. So what should we do? Should we hold chronic gabapentinoids for surgery? When should we stop them? Should we resume them postoperatively? And when should we resume them? Well, there's not a lot of information to answer either of those questions. If we look at the drug labels, for example, there's no useful or pertinent information. The labels talk about what you should do if you want to stop those drugs in patients, and they talk about the risk of seizures, but that risk is in patients who are receiving them for seizure therapy, nothing to do with routine use for pain. It says that you should taper them over the course of a week. But again, this is referable to seizures, not referable to the routine use for pain. If we look at the published information, there's almost no information. It talks about the potential signs and symptoms of, quote, withdrawal, but they're relatively rare and not material to our patient population. Over the course of almost 20 years of stopping gabapentinoids, there were 18 case reports of, quote, withdrawal, a very low frequency event. So I think that the concerns about patients going into, quote, gabapentinoid withdrawal if we stop these drugs before surgery is not material. So I think that it is relevant to stop these drugs shortly before surgery. Whether you stop it the day before or 5 days before, there's no evidence either way, unless you have patients that are receiving them for anti-epileptic therapy. And when should we resume them? There's no evidence or data which suggests when that safe period is, but given that the concern is the interaction between gabapentinoids and opioids, perhaps it would be logical to restart them a day or 2 or 3 after surgery when patients stop taking postoperative opioids. But the real take-home message is to avoid opioid gabapentinoid interactions. So with that, I will stop, and I look forward to taking any questions in the panel. Thank you.